reason why we wanted to do this chat in a really casual setting with a lot of great drink and imbibement was because we wanted to help you to understand how this very preventable disease of obstetric fistula can be overcome bit by bit with your help. And I want to start by mentioning that today is the UNFPA's International Day to Eliminate Obstetric Fistula. And this is not just like a one-time, few weeks, few months infection. This could last decades because of the lack of proper treatment, the lack of prioritization for maternal health by governments for the types of policies that are needed to put maternal health first for the sake of the population. And then in comes Dr. Sleemi with her team. And not only do they treat cases, they leave stepping stones, like a kind of framework to make sure that an upcoming generation of surgeons will know how to treat this, because it is a highly specialized surgery that the developing world does not put first. It's not on the front burner. And so Ambereen and her team have become really good at going to numerous regions around the world, in Africa, in Asia, in the Caribbean. So first, let's get right to the nitty-gritty. Ambereen, can you tell us about a case on a recent trip that may have involved perhaps a patient that we don't normally associate with fistula?
Most people hear a story, if you've heard about fistula, we hear about, a young woman whose first pregnancy goes horribly awry. And in most places, if you go into labor in pregnancy and the pregnancy doesn't progress, in other words, you don't give birth after 24 hours, 48 hours, day after day, you would have gotten a C-section. So in most places which have access to really good healthcare, really good hospitals, and good surgeons, OBGYNs, you'd get a C-section. The problem that we see are in places that don't have access to safe maternal care. Emergency obstetric care is not a priority, it's not funded, and it's not accessible. And that will lead to over 500,000 cases, some say 1 million untreated cases of fistula, with 50,000 cases every year that are currently developing. And I will say, in the context of all the global unrest, the wars that are happening, we expect those numbers to go up, because if you can't get to a hospital to deliver a baby safely, you're going to end up, if not dying. If you survive, 90% of the cases will have a stillbirth, which we also want to really highlight the trauma of that, and a fistula. So back to your question. No, we do see it in all spectrums of life. We have patients who have their first birth, they get obstructed and develop an obstetric fistula. We have patients with their third or fourth pregnancy. At any moment, the risk factor is pregnancy without access to care. So let's just, leave this stereotype of first pregnancy young woman. It really can happen anywhere. And if it happens and you don't get treatment, you can be in your 50s and 60s, like several patients. Every year we see many patients in all the sites I work in. And I was just in Liberia, and we had a patient, Fatma, who had, in her 50s, she wasn't exactly sure of her age, had had a fistula for decades. It was during one of her pregnancies. She lived in a remote area without access to any health care, and then heard about, through outreach that we try to partner with local communities to let people know that we're coming, providing free surgeries. She had heard about it and ended up in Phoebe Hospital, which is one of our partners in Liberia, and got treatment for something that she had been suffering with for decades.
So just so we understand what suffering entails, what happens when a fistula forms? So in this patient's case, for those of you who don't know, it's the infection that happens with the obstetric.
Right, so obstructed labor leads to tissue trauma, right? So it's like if you, and I don't know if it's a great example or not, but it's like if you pounded your hand against a brick wall day after day, it would cause a lot of damage. That's what happens when a baby's head hits against the pelvic wall, damaging the normal tissue between the bladder and the vagina, causing holes to form, which leads to leakage. And in 20% of cases, it can be both the front a vesicovaginal fistula, bladder to vagina, and from the back, a rectovaginal fistula, which leads to the leakage of stool. So the condition itself shows up. Again, a woman is labored, she's exhausted, she's lost her baby, and does not know what's happening when a few days later she just starts leaking urine. And depending on where you are, some people in the community, they think you might be cursed. They think certainly you might have lied. There are a lot of myths around why this happened. But what's really happening is that you didn't get the emergency obstetric care you needed. So this hole forms. And what the consequences look like, it's not just urine and stool, which is horrifying itself. But again, 90% of cases, over 90% end up with stillbirth. But there's ostracization, there is isolation, there's the inability to stay with your family, eat with your family, worship as you wish because of this condition. There's depression, there is being left by your partner. In many cases, women will go back to their family until they can either find treatment, if it's available, or live out their lives with their families. So it really impacts a generation of the most productive in a country, right? So these are young people that are affected by this. Young women, so you're also talking about a nation's, GDP and productivity. Like, it has pretty much a ripple effect beyond just I leak urine 24/7 or feces 24/7.
In Fatima's case, did she have a network? Like, how did she hear about the fact that you were offering these surgical services?
So one of the things that I love about the work that IMR does and how we function is that we partner with a local hospital. There's an agreement. There's an agreement with the local county health officers, for example, in Liberia, with the local UNFPA country office and the Ministry of Health. So all of our sites, we have multiple sites in about 5 or 6 different countries right now. They all have this network of everybody working towards the same goal, right? So we do the technical component, the surgical part, right? And in addition, we also do training of younger surgeons, doctors, and nurses. So we have this continuing network of people getting trained up the pipeline that can step in and then again train the next generation also. But it is through either word of mouth or county health officers, radio shows in some places saying that there's a team coming if you have this condition. Some places have a sister-to-sister program where the women and elders in the community go house to house and actually ask, is there anybody that has a problem with urine? And then we go from there. We do a lot of screening and then finding out who has the condition that we can treat surgically.
And it's unthinkable to even hear what you're describing in terms of what a woman may go through after the trauma of losing a child. She may be living with fistula and then feeling like she can't get any help. Is there a lack of knowledge about what exactly this is that also contributes to the fact that you're not putting up posters advertising that this is happening? There's a kind of word of mouth network that's helping to pass the word along.
There is a word of mouth network, but also again in partnership with the Ministry of Health. In some places, there are billboards, in more rural areas. We've got to find a better way to let people know, first of all, how it happens and why labor shouldn't go on very long, right? But then we need to also work with the policymakers about making sure there's access to care. So you can tell a woman in a very rural town that you can't labor for more than 24 hours. You have to go to a hospital. Well, there may not be a hospital. You may not be able to afford the hospital. Once you get to the hospital, there may not be emergency obstetric care and somebody who can do a safe C-section. So these are all things that multiple people at different levels have to work towards. For A, preventing it, and then B, making sure people who have this condition can get treated properly.
You don't take any money for the surgical procedures that you do. You allow a woman to have pretty much a normal life after she heals following the surgery, at least more normal than what she had before. You also don't take any money to train these surgeons. So can you help us to understand, as first worlders with first world problems, what kind of money are we talking about? How much is that surgery? How much does it cost to train?
So there are estimates depending on which country we're working in, but each country, depending on how much things may cost, it can be anywhere from $300 to $500 to help restore a woman's dignity and her chance at what we would consider a normal life, to reintegrate into society. I think that's a very small price to pay. We provide, free training, free surgeries, but we work in hospitals where the staff need to be paid, the OR techs need to be paid. As much as we provide free care, people who are working day in and day out need to also get paid for their work, right? We also have to bring people in through transport. I mean, we're talking several days from where they live to bring them into the hospital, to do the lab work and tests that's needed. And then after surgery, people need to stay at least 2 weeks to recover, 2 to 3 weeks, and then a little bit of extra time if there's a rehabilitation service that's offered too, So in all, I think it's a really small price to pay to help restore dignity and give a woman her life back, or a chance at what we would consider a normal life, to be fulfilled, to have a family, and to just go back to her community and become productive and, fulfill her dreams.
You've done how many surgeries?
Thousands. I think the last count was probably over 3,000.
How many have you trained?
Dozens. So we really focus a lot on surgical training. One thing that Vivian had mentioned is that there's an estimate that for every one surgical case that we do as surgeons, there's at least 50 women that don't have access to treatment. We know that there are almost 1 million women with this condition. We know that more cases form every year because we haven't been able to literally turn off the tap on new cases, right? There's a lot of people working on that end, on the prevention end, but we're not nearly where we need to be. And so we're still gonna need a lot more fistula surgeons. And I think that that's something that IMR is really unique in, that our focus is always with the partner hospital that has trainees that will work with us for every case. So every case I do has another local surgeon next to me. And then over time, just like with any fellowship, just like with any training, you have a transfer of technical skills that will then go on to train, again, another cohort of surgeons.
Why is that so important? Because there is just no training of this kind of surgery happening in those countries where you go?
A lot of it, I'll tell you, is because our patients are poor, and so it's not lucrative. So it's really hard to get younger surgeons, or surgeons in general in places, to commit to taking care of people where they don't get paid. So it takes, I'm going to say that the people who work in this world are remarkably incredible people. I have the opportunity to work with the most amazing surgeons and teams around the world, because it really does take a certain kind of person to come into this kind of work. But even if they don't do it full time, if you can get people trained so they can at least provide the service for free or train the next generation, it would be huge.
Final question.
Yes.
I know you're going to Ukraine. You're not focusing on fistula treatment specifically there. Can you talk a little bit about what you will be doing in Ukraine?
Absolutely. So in Ukraine, again, fulfilling our mission of training the next generation of surgeons and physicians, we work with the medical center in Uzhhorod, and between expertise in emergency medicine and gynecologic women's care, we've been able to take a cohort for the last year. This will be our third trip, working with the family medicine residents and the medical students in Ukraine. So that's, again, part of our mission statement, part of what we've committed to do. So it's another aspect. And then right after Ukraine, I'm actually flying to Gambia to start one of our newer fistula projects and gynecologic surgery projects with, again, partnership with the local hospital and the Ministry of Health.
You're just not busy at all. Ladies and gentlemen, Dr. Ambereen Sleemi, thank you.
Thank you.